Menopause, the facts. Thank you for completing part 1 of this study already. Watching this video is part 2. After watching the video, you're invited to answer a small number of simple questions in part 3. Your participation in all 3 stages is important to help us judge not only current levels of knowledge and understanding on the topic, but also the impact of this educational course. Learning objectives. Understand the transition to menopause, awareness of common symptoms associated with perimenopause and menopause, and the associated physiological changes. Learn questions to ask of patients who present in clinic during this time, and know about appropriate signposting to services or resources for further help around menopause. So what is menopause? The end of the reproductive cycle where ovaries are no longer releasing eggs. It's characterized by significant hormonal changes with drops in estrogen, progesterone and testosterone. 75% of women experiencing symptoms, only 10 to 15% will seek support from healthcare professionals. Menopause is defined retrospectively once women have not had a menstrual period for 12 consecutive months. And the perimenopause is the time leading up to a woman's final period and the physiological changes associated with this. Average age of onset for this is 47.5 years, with an average duration of symptoms of approximately 4 years. Symptoms of the perimenopause begin with menstrual irregularities, including erratic and very heavy periods, and other typical symptoms include hot flushes, night sweats, mood changes, altered libido, urogenital symptoms, sleep disturbance, and cognitive changes. So, how do we diagnose menopause? A perimenopausal or menopausal diagnosis can be made for healthy women over the age of 45 who are not using hormonal contraceptives based solely off the symptoms as described previously. Lab tests such as follicle stimulating hormone does not test with diagnosis due to hormone level fluctuation at the time of the perimenopause. And furthermore, knowing these levels will not alter the management. So when we consider female hormones, specifically we're considering estrogen. Estrogen nourishes the tissues, maintaining integrity, reducing inflammation, regulating bone growth, and supporting the regulation of body fluid to maintain cell hydration. Progesterone supports mood, maintains a sense of equilibrium, and increases pain threshold. And testosterone supports and increases bone density and assists in transforming fat to muscle and is central to libido. The graph on the left represents a woman's life in hormones and significantly illustrates the dramatic drop around the perimenopause of estrogen and progesterone, with a steady decline of testosterone and also the influence of age on the melatonin. So what are the syndromes of menopause? The most commonly described symptoms are around the genitourinary syndrome of menopause, those being urinary incontinence, bladder frequency and urgency, urinary tract infection, vaginal dryness, vulval pain, and sexual dysfunction. But there are many musculoskeletal symptoms generated by changes that can be associated to hormonal changes in menopause. Symptoms driven by bone loss, significant osteoporosis, muscle loss, sarcopenia, muscle weakness, frailty, and fractures. So what are the key changes that one might expect to see due to changes in estrogen? Estrogen is an inflammatory regulator with a key role in the prevention of generalized arthralgia and the subjective experience of joint pain, so a significant influence on the pain processing pathways. Although biochemical and mechanical factors contribute significantly to OA progression, OA incidence increases significantly around the menopause, and evidence supports that women suffer much more debilitating pain than men, and the possible association between menopausal drop in estrogen and the frequency of hip, knee and finger OA is supported in the literature, as well as severity of hip osteoarthritis. So to summarize, the primary changes due to the drop in estradiol being the most biologically active of the estrogens, is inflammation, so the joint pain, the generalized arthralgia, sarcopenia, the age-related loss of lean muscle mass, the poor muscle recovery and repair following injury, bone density with the significant bone loss or osteoporosis that leads to increasing fragility and risk of bone fracture and developing chronic pain. And then there's association of estrogen with the health of synovium and cartilage, therefore drop in estrogen creating cartilage damage and leading to osteoarthritis. Now moving on to think about the pelvic floor complex. This is so much more than the pelvic floor, traditionally considered as the diaphragm of muscles at the floor of the pelvis, mainly associated with pelvic viscera support and the maintenance of continence. But actually, it's a complex three-dimensional functional unit comprised of urogenital viscera, the bladder, the urethra, the vagina, the uterus, the anorectal viscera, the rectum, the anal canal, the pelvic floor muscles, the connective tissue surrounding and supporting them, the endopelvic fascia, the nerves, and the blood supply. So continuing on the theme of pelvic health and what contributes to a functional pelvic floor, the components of pelvic floor function include the ability to support breathing, to support pelvic organs, to control the bladder, to control the bowel, to control the passage of urine and feces, to support pregnancy and facilitate childbirth, and to support healthy sexual function. Pelvic floor dysfunction encompasses over 250 symptoms related to bladder, bowel, and sexual health. The significant overlap that exists between all these symptoms adds to the complexity and the challenge of appropriate management and underpins the common multi-system symptom presentation that exists in these patients. What do we mean by that? Rarely do you find that a patient will present with urinary symptoms in isolation. There's often an element of bowel symptoms coexisting with an element of support dysfunction, with an element perhaps of sexual dysfunction, and then perhaps a pain component. Integral to understanding pelvic floor health and pelvic floor function is an understanding of the role of the abdominopelvic canister, and specifically the optimal synergy between the breath cycle, the pelvic floor, and the transabdominal activation. This generates the appropriate tension to manage fluctuations in abdominal pressure and adjust the pelvic floor support accordingly in line with the demands of the functional task. So on a practical level, you need to explain to your patients how to facilitate optimal pelvic floor activity. We need to initiate the pelvic floor contraction on the exhale, not the inhale. And this diagram shows you that in a dynamic sense. When we inhale, the diaphragm flattens. We do not need the recruitment of the transabdominals and the pelvic floor muscles in order to generate the appropriate amount of abdominopelvic tension to allow us to transfer weight and maintain the integrity of the pelvis and all its functions. But on the exhale, this is when we do need to facilitate the pelvic floor and the transab in order to add the support needed to provide the appropriate tension to manage abdominal pressures and create function. So think about the E's. Exhale, engage, on the effort. So what questions can we ask that will offer insight into bladder health, bowel health, and sexual health? And crucially, whether this person needs signposting to a specialist pelvic physiotherapist. For bladder health, you could ask questions like, do you feel you need to go to the loo more than you used to? Can you hold your pee? Do you ever leak on exercise or if you don't get to the loo on time? Or do you feel you empty your bladder properly? For bowel, do you empty your bowels regularly? Do you ever have to strain? Do you struggle to hold when you need the urge to go? And is there any leakage, either passive or urge, experienced? And for sexual health, are you sexually active? Do you experience pain associated with sexual activity? If so, where is the pain? And does it stop you being sexually active? A common factor within this presentation raising awareness on symptoms generated by the musculoskeletal syndrome of menopause is the concept of pain. So let's remind ourselves what the definition of pain is: an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And key to this within the context of this presentation is acknowledging that pain does not always correlate to mechanical damage and might be associated with changes attributed to the musculoskeletal syndrome of menopause and the associated hormonal changes. And finally, it is hoped that after listening to this presentation, you'll have a greater awareness of the musculoskeletal symptoms generated by the musculoskeletal syndrome of menopause, an understanding of additional questions that are asked during your assessment that might provide greater insight into understanding what could be driving these symptoms from a pelvic health point of view, and then ultimately able to signpost them to specialist pelvic physiotherapists for further management.